Good afternoon, and welcome to Clinical Integration as a Key to Value-Based Care, a complimentary webinar from healthsystemCIO.com, sponsored by Perceptive Software. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemCIO.com, and I'll be your moderator today. We encourage you to ask questions at any time. Go ahead, type them into the Q&A box in the lower right-hand corner of your screen and leave the default set to all panelists. You can send them in at any time, but I'll be holding them, posing them later in the program to our speakers. You can download the deck at any time. I see the URL in front of you. There's a shortened URL at the bottom of all the slides, and I will also send it out in the chat box, so you'll have plenty of opportunity to grab the deck that you'll be seeing today. And we are recording this event, so you will be able to see the archive. It's usually ready within 2 business days. You'll get an email, and a separate registration is required. Just so you see how we're going to spend our time today, we're going to go about 45 minutes. First, we're going to hear from Dan Kinsella, EVP and CIO at Cadence Health System. Then we'll hear from his colleague, Dr. Tom Moran, CMIO at Cadence. Then we'll hear from our sponsor, represented by Thomas Picard, Director of Healthcare Industry Marketing with Perceptive Software. And then we'll have our Q&A with our speakers. So without further delay, I'm going to turn it over to our good friend, Dan Kinsella. Dan, thanks for joining us today.
Thank you, Anthony, and thanks everyone for joining. Just a little bit about Cadence Health and Northwestern Medicine. We merged with Northwestern as of September of this year. Cadence Health combined with Northwestern is about a $3.2 billion organization with 24,000 employees. Our journey to value-based care really kicked into high gear about a year ago with some new leadership and investments in technology. Today we are CMS, MSSP contract award winners. We've got an employee cohort of about 10,000 lives and some Medicaid and other commercial contracts pending. So we're happy to share our experience and lessons learned so far. So in terms of learning objectives, we want to make sure that we establish an understanding of what we mean by clinical integration in the context of value-based care. We want to talk a little bit about the value chain of value-based care and how you can consider where you are in that journey. One of the key things here is suggested synergies between value and volume-based care. Well, volume-based care referencing pretty much the traditional, the more we do, the more we earn type of care. And then our lessons learned. So the context for healthcare transformation, changes in our industry continue really at a dramatic pace, creating pressures on operating margins, increased consolidation, narrow networks, really incentives for what I call a hybridization of finance and delivery mechanisms. So you've got payers buying delivery capacity, and you've got providers developing insurance capacity, and a migration to value-based care is coming out of that. So once again, I've been in the industry more than 30 years. We're at the precipice of another transformational change, requiring dramatic and rapid changes focused on value. So clinical integration, it's important that we define what it is we're talking about. I think it's one of those things, if you polled 5 people at HIMSS what they meant by that, you'd get 5 different answers. But so on our journey to value-based care, clinical integration is one of a handful, so there's not 100 of them, there's probably 8 or 10 high-impact capabilities that will really add value to our business as we get more advanced. So the concept of a high-impact capability, as you develop maturity in that, you develop value for your enterprise. So what is clinical integration? At the very basic level, I call it sometimes lowercase CI. We talk about clinical integration as a stamp of approval, if you will, to do group contracting across owned and affiliated providers without the risk of antitrust. That's an objective that providers have pursued for 15 years. That's the very foundation of clinical integration. At a more mature level, clinical integration, big C, big I, is about the secure sharing of selected portions of that medical record for a specific patient among an authorized set of providers involved in the coordinated care delivery, whether they're employed, affiliated, et cetera. So that's what we mean when we talk about clinical integration. So our national healthcare reform agenda has really been anchored in the pursuit of the triple aim, and I argue that 2 of the 3 of these are really not draconian. Better outcomes, improved patient experience. To me, that's the jumping off point for the synergy between volume and value-based care. Lower cost doesn't necessarily mean the business is going to dry up and blow away. In terms of better outcomes, we're looking at extending our zone of influence to more closely match that with our control of a network. So we ensure closed loop and referrals, make sure the information flow is there. That's part of clinical integration. Advanced capabilities such as registries enable focused program development around better outcomes, the greatest needs within the cohort of patients for which we're accountable. In terms of the improved patient experience, by confirming the shared information versus collecting it new each time there's a visit, certainly improves the customer experience and also better outcomes in terms of being aware of the complex multiple diagnoses that many of our patients have. And through the, in terms of lower cost, through the better sharing, we're going to have the most appropriate care for the individuals at the right time, thereby reducing cost. And we can also then avoid duplication of tests and procedures, for example, image sharing. These are just an illustration of many of the technology components that can enable clinical integration. Our strategic IT plan really considers our measured investments in these components over a 3-year window of time. And a couple of observations I would offer is that you may already have many of these elements, either in operation or in your near-term plans. Second observation is really, you can't buy this in a box. There's not an all-in-one kit to enable clinical integration, and that these are not of all equal value to each organization. It's really relative to where you are on your journey and your relative maturity. So, what you do first, now, next, and later is important for you to consider. This is getting a little deep, but when you think about value-based care, which is kind of the new way of working, we offer this framework for considering where clinical integration comes in. Note that at the bottom, the IT enablers really are just that. They enable respective business functions. It's not the tool themselves that get you in this, but that you should measure your specific investments to what makes sense for the volume of your business and the complexity of your contracts. So just to kind of drain and explain this chart, if you look left to right, payer contracts are where it all starts. The payers have, for the most part, they have the money, they set the rules, and they drive the patients. Some of the success metrics there you want to look at are the number of lives under management and a portfolio of profitable contracts. So you're expecting to have, as we are, multiple payer contracts. And when you've seen one payer contract, you've seen one payer contract. So there'll be nuances in each. The second chevron deals with the provider network. So, in order for clinical integration, you need providers based on specialty and geography in adequate supply to meet the terms of your contract. Dr. Moran's going to take a little deeper dive in that in terms of some of the physician and non-physician provider types and some of the challenges of clinically integrating those. The third chevron deals with patients and members. Certainly can't, that's the focus of it, but even introducing the notion of members, which is part of the phenomena we're dealing with, the hybridization of payers and providers, the concept of a member. So you're responsible for the health of a person who may or may not have a medical record in your enterprise. So we want to make sure that we get members attributed to the right providers. We need to manage their retention and satisfaction and engagement in order to do those things. what I really think is the secret sauce of value-based care is the next chevron, which is care coordination. And Dr. Moran is going to talk a little more detail about that. But in terms of bending the curve, that's where you engage with patients and get them in the right venue. And then finally, you need to manage results. You need to keep score. You need to understand how you're doing relative to the contract. So, you can see some of these things really offer some synergies between both the value and the volume-based contracts that you might have, parts of your business. So it's important, too, to consider the scale of your new value-based programs. This framework may be helpful to help you mitigate what I describe as the duality challenge. I'll explain a little bit of that. If you look at the cube on the right, you've got patients and providers. In the first cell, bottom left, cell A, may represent, for example, your cohort of patients for whom you're accountable. Let's say it's our primary care docs supporting our MSSP contract. So a finite number of patients and a defined number of providers responsible for taking care of that cohort. Cell B then, above A, represents the other patients that are seen by those doctors. So that starts to introduce this concept of a duality challenge. You don't want to have a gold door and a wooden door for two ways of handling people. Cell C then deals with additional providers contributing to the care of a specific cohort. So again, with that same example, the MSSP cohort, while we have PCPs who are driving attribution, we're going to have specialists and others that would be defined in the C cell. And just as B is to A, D is to C. And so in those offices and those practices where these specialties are practicing, we want to make sure that we're thinking about how the workflow works and how the programs are affected. And then E represents the universe of everybody else. So I think it's important when you think about what you're going to implement, whether it's a nurse call system or a care advocate program, for what volume of patients in what offices are you planning to do something like that. So I think right now I'm going to turn it over to my colleague, Dr. Tom Moran, who's the Chief Medical Information Officer. He's going to cover some more concepts and share a bit more about our experience at Cadence and Northwestern.
Thank you, Dan. Thanks, everybody, for tuning in today to listen to us about what we have kind of gone down the road to accomplish for not only value, but really volume. Because when you think about what we're trying to do, we're trying to enhance that time of a provider is with a patient. There is time in the office, and there's time, much of the time, when you think about it, is outside of the office. So when you divide it up into before care, during care, and after care, you have to kind of look at it in a way of the before care of the system is you need to contract and connect with providers and payers. So you have a system that you could kind of manage. You also then have to have the during care part of it is how do you manage those patients directly? So what do you do for them to provide service, to get information to providers, to enable them to be able to access the system in a way that meets their needs, because they're customers first. They have choices at times of where they could go on the volume side. On the value side, they get limited. But to providers, we don't want to make like Dan was saying earlier, there isn't two ways of managing a patient. We want to come up with a way that by enabling the before visit so that we have the information that we need to process, that turns that data collection point into informative information to make decisions on patients so we don't replicate information and we provide them relevant information to their healthcare, they become a little bit more engaged with themselves to help us. And then there's the aftercare. How do we manage ourselves, not only of the patient, but do we have a kind of scripted way of transferring patients between providers, those that are on our EMR and those that are off our EMR that are our affiliates? So we want to really make that interaction with the patient more meaningful. And to do that, we really truly have to build a changed culture of both the patient and the provider. It's a process, and it will reduce duplication of services because we provide information that says this has been done. You don't have to go and look for it, but you have to be able to see it in your everyday workflow. And then you look at access. There's patient access and there's provider access. So when you kind of build an integrated system, one of the things that we kind of want to break down in a big barrier is the rules of getting a patient in to see somebody. So patients leave an office and we say, go make an appointment with Dr. Smith. And Dr. Smith has very certain rules of how that patient could get scheduled. The access for that patient is limited. So in an integrated system, by getting doctors to go along with the process and providing open scheduling, the patient could self-schedule themselves into that visit. And then on the other side is also the ability of a provider to not have to jump through hoops to get a patient seen by a specialist. We don't want the backdoor phone call and that's the only way you could get them in, because we want providers to really care for patients consistently, provide services that enhance the value side, but also drive that, boy, I'm actually getting cared for, they think about me, and they made it simple for me to go to a specialist, a service, a location to get something done. If you look at the network, there's your core, like Dan was saying, you have your PCPs who are employed, and you have your patients that you're on the hook for. If you look at your secondary members, it's those that are affiliated or those doctors that truly are taking a stand to say, this is going to be my home. I'm going to really kind of affiliate with this institution or health system to care for my value business, but also drive my volume business. And then you go into the outer circle of patients can still access healthcare outside of your service areas. How do you get that information back into the system so you manage those patients even when they're afar? When we're on the hook for many patients, especially members of the family of employees or contracts, they go all over the nation to get cared for, and we need that information to come back to us so we can manage them in a structure that guides them through their health. So care coordination, which Dan talked about, the secret sauce. We want to engage our patients in a way that we are able to connect with them, provide them information, and at the same time, we want to institute care or coordination of services that actually decrease our costs as an organization. So if you look at through the gradations of it, there is tiers of patients. Tier 1 patients, those are our sickest patients with the highest costs. Tier 2 patients are those with chronic illnesses, 1 or 2 of them, but don't need the extensive care that of a Tier 1 patient. And then Tier 3 are really your healthy patients. And if you look at the kind of walk through the slide of nurse line, care transitions, chronic disease management, and care advocate, a nurse line is that information source that patients can ask for information or feel connected. They don't have to go to multiple different places to find out where a service is, I have a question, where should I go to get something done, or how do I get in touch with my doctor? It is a scalable thing to reach to everybody, both value and volume. They reach pretty much all the patients that can interact with your system. You don't have to have someone that's employed, that's in your cohort that could use that line. And as you move through the stages of this, once your patients are in the hospital, those that are being cared for by your providers, how do you transition them to the next zone, either skilled nursing, home care, or long extended care facility? So you need a process that says, I have people that understand our affiliates that we have contracted with and know that provide the services and the information back to us so we can manage those patients. And then you get into the chronic disease management stage. Those that need extra help, management not only through the ability of a person, but the system. So chronic disease management needs lots of things. You need to be checked on. You need to make sure you get labs done. You need to have visits. And this is where you throw in the management of that with an individual and also the system. So you can leverage some e-visits, those that are done for chronic disease management of, I need to make sure you get these tasks done. You haven't gotten your A1C done. Messaging through the system that gets to the patient and they get a notification that they need to get something done. To video visits, that I need to see you without you having to come in because it could be difficult for you to come in. So I can manage you to take a look at how you are progressing and make sure that I capture that information into the system so we could follow it and track it. And then you get to the care advocate, which is really, these are your complex cases that are coming in that have multiple specialists that are dealing with them, high-cost drugs or treatment plans that go along with them, and making sure that they get plugged into the right plan, the right location, the right service line to get that done. Population health with clinical integration. If you look at what we're really trying to do, and I kind of break it down into collecting information means we got to make actions, results, progress, and outcomes discrete. We don't want to try and place something into the record that causes us to go do CSI work to find it. If we value that data that we want to collect, then we have to make a process that is simple and easy for clinicians to enter that data so we can extract it. When you get into analyzing that data, you have to come up with some clear definitions of what you agree to that you're truly going to analyze, what parameters of that data that you're going to agree to so clinicians believe it. You don't want to produce results that they say, well, that's not my patient's, or that wasn't attributed to me because I didn't have anything to do with that. And you want to keep it simple in the beginning. We don't need to go to college level course in the initial part of who is our sickest patients. Almost all the providers know who the sickest is. We have those care classes of diabetes, congestive heart failure, COPD, et cetera, that we know they need extra disease management for them. And then you have to be able to give that back into the frontline workflow that they can take that data and it's information that changes care. And then engage them. So you have to produce that information across the continuum of providers, not only the direct physician caregiver, but you have care coordinators, you have mid-levels that will work with that patient to make sure that their information that you need to change or guide their health is conveyed to them in a concise way. When I look at this, of how we do it, there's systems that we put in place. There is lots of IT infrastructure, but unless we get the buy-in of the providers that make their clinical day-to-day workflow relevant, that I'm seeing stuff that I don't have to go look for, that I have the ability to analyze it in a way that makes it simple and concise for me to reach my patient, and at the same time I have the ability to give that information to my patients to engage them in their own health, we make a difference. Because it's not really the system in general. It enables, like Dan says, but it's provider workflow and clinical pathways that are consistent and easy to do that makes a difference in population health. So in closing, when we look at this, integration is really, it's an enabler. What you do for the value base enhances that customer who is in the volume because they want easy access. They want a phone number to call to be able to say, how do I schedule this? They need to have the availability of imaging labs that is convenient. Our world works in 24/7 now. There is lots of patients that can't come in on days of regular business hours to get services done. And then the other side of it is we need to be very scripted in how we develop the program because everyone wants to get the thing that is like the Watson computer to analyze all your patients and give you this risk stratification score instead of focusing on those that you know. You know your diabetics, you know your CHF patients, and you know your COPD patients that you could start work on now to make a difference. And there's lots of different things out in the marketplace right now. So really beware of the glossy brochures that you get. You want to investigate it in a way of how it's going to be applied for my providers and how it's going to make a difference in the day-to-day workflow, because reports are great. They make great sense, but they're very much after the fact. The patients have already gone and left, and you're just basically telling the providers to do a little bit better next time. So we want that functionality in front of the doctors. So they see, this is my patient today, this is the gaps in their care right now, and I can do something about it, and I'll get credit for it. So now I'm going to pass it back to Anthony, and we're going to go with a comment.
Very good. Well, thank you so much, Dr. Moran. And as you mentioned, we're going to now turn it over to our sponsor, who's represented by Thomas Picard, Director of Healthcare Industry Marketing with Perceptive Software. So, Thomas, thank you so much for sponsoring the event and joining us today.
Why, thank you, Anthony, and thank you to Dan and Dr. Moran for your comments this morning about clinical integration. So just building a little bit on their comments around this change from volume to value, the Affordable Care Act, as we know, is making a tremendous, well, it's beginning to make a tremendous change in the way that we deliver healthcare. As Dan said, it's a transformational change. And so all of us on the call really are kind of listening, I think, because we're trying to hedge, because we know this is going to happen, but we're trying to figure out, when is it going to happen? And our belief of Perceptive Software is that this is all driven by an unprecedented demand for information. So this slide shows the growth over the last 20 years. Many of us have been in this industry for a long time and have seen this change in the imaging side from PACS starting with radiology and cardiology, and over time now moving into larger data sets, as you see on the right. And this information being shared with larger numbers of people, including on the left there, you see the patient actually being involved in this process. So more and more people wanting to look at information, the information itself is growing. So our take at Perceptive Software is that the integration of back-end systems is going to be more increasingly important as hospitals merge, as we heard today with Cadence and Northwestern. About 20% of us, or 1 in 5 of the folks on the call, will probably be involved with a merger in the next 4 or 5 years. So there's a good chance that clinical integration will involve the integration of many systems. So at Perceptive, that road to clinical integration takes the form really of 3 main areas. And these range from very specific solutions that we call enterprise content management that puts business and clinical documents at your fingertips, the vendor-neutral archive, which is primarily used in medical imaging but handles all kinds of enterprise viewing, and then finally enterprise image connectivity, and these are solutions that allow you to capture video, for example, or integrate information with your electronic medical record. So there are lots of different ways to get there, and I think the importance for a vendor like Perceptive is getting the message across that you need an approach. And the approach that we use is something we call healthcare content management. And we see ourselves now as a company that sits between the clinical content that exists in the EMR that doesn't have a home in the EMR, so you need a place for that, and then also integration with business applications. So you may have patient financial services, or you may have, an invoice comes in and you need to look at the information from the invoice and marry that with clinical information that may be a medical image. And so that's really where we're playing in this space at Perceptive, is the intersection of the world of clinical and business content. So just a little bit more about Perceptive Software. A lot of folks haven't heard of us before. We were founded in 1995 in Kansas City. Starting off with enterprise content management was the basis. We've now broadened our portfolio to be this broader healthcare content management. Through some acquisitions now, we have over 3,000 customers. Our software is deployed in over 30 countries. Perceptive itself was acquired about 5 years ago, and then you can see some other companies in healthcare that have come together under Perceptive, including the Perceptive AccuO VNA, recently the Claron viewing technology from Canada, and the company that I came from, PaxGear, which is involved with capturing documents and video. Perceptive, in turn, is owned by Lexmark, a very large company that has worldwide offices, mainly known as a printing company, but really is in the business of managing information workflow. And so we're seeing the convergence of healthcare customers for Lexmark and Perceptive. And again, just a few notes. If you've never heard of us before, you may have heard of those individual companies, but together we actually present a better picture, and wanted to let you know we are a best-in-class vendor for the products that we sell. We're known as a market leader for our VNA technology. Gartner sees us as a leader for enterprise content management. And finally, the solutions for image connectivity have been deployed in over half the hospitals in the United States. We now have 100% of the U.S.-based hospitals that have achieved MRAM HIMSS Level 7 compliance are using our solutions as well. And we, of course, welcome you to visit us at HIMSS in a few months so that you can, as Dr. Moran was saying, kind of separate the wheat from the chaff and find those solutions that actually work for you. So we have time for a few questions. I'll turn this back to Anthony, and once again, thank you for spending time with us this morning.
Well, very good. Thank you, Thomas. I think you had one more slide, but we will let that be for the people to see when they download the deck. So thank you again for that. So now we are ready for our Q&A, and I do already have a question that has come in. So let me pose that to. We'll start off with you, Dan, and then Dr. Moran can add comments if he'd like to for this particular question. Are the Cadence and Northwest hospitals on the same EHR? What are your strategies for integrating clinical records, either by migrating to a shared system or by using an HIE? What have you seen for a cost benefit in regard to a single IT platform? So you got a few things there. Dan, what are your thoughts?
Yeah, certainly. So Cadence and Northwestern, the merger is official September 1st of 2014. So we are not yet on a common platform, but it is central to any strategic vision that we have for the future of, establishing a contemporary academic health system, not an academic medical center, but a health system. So hybridizing the power of the community delivery model with the essence of a top-tier academic medical center with the research and the education. So clearly an enabler of that vision. So, but we're not there yet. It is front burner in terms of how we're going to get there, though. It's clearly a job one. So in terms of the strategies for how we might do that in general. So even if we were able to wave a wand and be integrated with our new colleagues, tomorrow, we have additional challenges of integrating to another extent with other providers who may contribute to the power of our network. And so we are adopting tools that are embedded in our enterprise platform in the HIE space for sharing records, with similar customers who are on the same platform and with others. In terms of the cost-benefit question, I don't know if there's been from the first RAND study out there in terms of a pure ROI with like a net present value that would dazzle finance on the single platform. But we believe that with the economies associated with platform consolidation, as well as the benefits associated with more consistent measures of quality, managing referrals, delivering a more consistent patient and provider experience across our health system, that there'll be many benefits to help offset, at least in part, the investments that we're making and will make. Tom, I don't know if you add to that. Or, yeah, go ahead.
Well, Dr. Moran, let me maybe pose this to you. A lot of times, with especially mergers and acquisitions, we have a large group of employees/physicians that are asked, as a result of what's going on from a corporate level, to learn a new system. So what are your thoughts around that and getting them to sort of embrace the new world, learn a new system? How hard is it once they've adopted a system to get them to be willing to embrace another one?
I think the biggest thing is getting physician champions to be involved in the process of what you're going to do for change, how you're going to do it, and to be part architects of the solution. So once you get them to understand that something's not being done to them, that they're part of the solution to make it more efficient for them, to provide the not only what I need to do to the system to place information into it, but how I'm going to get information out of the system, the change becomes just part of the process. Because if they just take it on as this is being forced upon me, they're going to dig their heels in and not going to change at all. We've gone through kind of a management of when we formed before we merged with Northwestern, we were a single hospital and we developed a Cadence health system and took on another hospital. Before we were even merged with that hospital, in the planning process, I took the docs leaders that wanted to be involved and incorporated them into the architecture of what we're going to do as we develop the system. And the implementation from one hospital to the next hospital with involving all the doctors became much easier because everyone was involved in the very beginning and understood what we were trying to accomplish, understood what we couldn't accomplish, and they were more of a sounding board to the rest of the medical staff of what we were going to get. Instead of complaining about the things we didn't get, they championed the 90 to 95% things that are great in the system instead of complaining about the things that aren't.
Very good, very good. Do you know what, Dan, do you know what you're going to be doing from your, the imaging perspective? We talked about the EHR, but what about on that front?
Yeah, so imaging is a complex solution area. We have previously made investments in our enterprise platform and then anticipating merger integration, and do have a vendor-neutral archive that we're starting to populate. And, you know, we have consolidated our cardiology PACS platform onto a new vendor, and we'll be, you know, really following a strategy around deconstructed PACS. And that's helpful as we continue to, you know, merge with Northwestern and then collectively then acquire, you know, additional assets. So it's a big, that's not an overnight solution because of the challenge of transferring images to something like a VNA. But, we're on that path, and it's an important piece of it. You know, part of our vision with the VNA is that we'll be able to source images from all modalities from a single source so that they're easily accessible within the EMR.
Very good. One of the issues you brought up in your slides was how to, the synergies between the volume and value-based care worlds. And you know, many times it comes up the idea of moving to a value-based world but living in a volume-based world and not getting ahead of yourself before the payment structure has caught up, so you wind up you know, in a value-based world, but you're still getting paid for volume, and you cut your volume because you're doing so well in the value model, and then all of a sudden you're out of business. So I know that's an oversimplification and overstatement of the danger, but just go into a little bit more about your idea of the synergies and living in both worlds at once.
Sure. It's like any you know, segment of the economy that's in transition. There's an old business curve that's, you know, established and declining, and a new business curve that's emerging but not yet sufficient to sustain, you know, your financial goals. So you really are living on two change curves. And, you know, as we talk about, you know, I think the genie's out of the bottle on value-based care, whether it's, you know, medical home or ACOs or bundled payments. We're going to have to be more creative. And so I think, you know, we need not be fearful. Certainly we enjoy our, you know, and we've invested a lot in terms of our strategic service lines based on quality top decile quality in high-end services like joint replacement and oncology and cardiology and all of those things. And so some of these tools also help with that volume-based business. So it's like, having people feel special as they're, getting some of these services. But then the other thing is that, as you think about the cannibalization of if you do a good job in managing health and you have some erosion in your inpatient days, the expectation is that you do a better job of managing referrals and end up, with less leakage, potentially having, a net increase that covers any erosion. So, time will tell, and the metrics will support that, but that's part of the thought. So don't be afraid to jump in the pool.
Dr. Moran, anything to add to that?
Well, I would go along with exactly what Dan said. I mean, when you think about it at the clinical level, what you're doing for the patients is the same. What you're trying to accomplish for them is the same. The enabler that really makes it different is that, it's the relationship management. It is, they know about me, they care about me, and they make it easy for me to get things done. Those things work on both sides of the coin, and it would be a gradual process as we move from volume to value, and I don't think volume's ever going to go 100% away. So it is to the doc side of it, let me do what I need to do in a consistent way. You worry about the business side of it because I'm going to produce the quality.
Very good. You both, well, in your presentation, you've taken, I would say, a very, very high view of things, which is important, almost looking at the ecosystem of not just the health system, but the payers and all that. I would imagine you would say that's very important for your colleagues to do when evaluating clinical integration and the changes going on in healthcare, that they have to take into account all these constituencies and not just look at their health system in a bubble. Maybe you can just explain that a little more. Dr. Moran, why don't you start?
So we don't exist in a bubble. There are patients that go to other organizations that are not going to be either owned by us or affiliated with us, that are going to be on our dime. And we're going to need to be able to partner with them to get what we want done for the patient, what is the care plan for that patient. So we need to be able to provide that to them. And at the same time, we want from them to be able to get information back on the outcome or progress of that patient. Because if we don't get that ability, we're not going to be able to manage that patient. So you do become partners with your enemies in a little sense of the word, because they need that on our side too, because their patients are going to be coming over. So the more we get to share information in a easy, organized format, it is, encapsulated a little bit. It's not everything, but you don't really need everything to care for the patient. You need specific things to see that they've been done, need to be done, or what is the plan that is for this patient down the road. And if that is exchanged back and forth, you have a much better system of your own and outside to actually make a difference in the community for the patients you serve.
Dan, anything you want to add to that? I think that's going to have to be our final question today.
Yeah, I would just comment that in terms of the payer-provider collaboration, that's, the market is driving us toward each other. So as I commented, the first chevron of the value chain of value-based care is the payer relationships. And most providers today are payers in a certain sense. I know we're self-insured, so we have kind of the dual challenge of, providing care, but also ensuring, the health and well-being of our employees. Part of the challenge in the market today is we have solutions, technology solutions that are proven in the payer world, things like case management and call centers and that kind of stuff, actuarial risk calculators. And then we have solutions in the provider world that are proven, like electronic medical records and imaging systems. And the set of solutions that we need is really kind of we're trying to perform unnatural acts with tools that are born out of either side. And so it's that middle space that is part of what's making it challenging now.
Excellent. Well, I think that was a wonderful webinar. I appreciate your participation, Dan, and Dr. Moran, thank you so much. I want to also thank Thomas Picard and Perceptive Software for sponsoring the event. You can see their URL for their website. As I mentioned, we will have an archive available of this event. It'll be ready within 2 days, and you'll get an email, and a separate registration is required. Attending our webinars gets you 1 CHIME CIO credit. So if you have that credential, go ahead and let CHIME know you attended, and if you've asked us to let them know, we will. Questions, comments, as always, please email me, and you can go to our website to view our upcoming schedule and see our last 12 months of archived events. So with that, I again want to thank our speakers and our sponsor, our attendees, and everybody have a wonderful day. Thank you.
Thank you.